Okay, guys, so we're starting with chapter 30, Adrenergic Agonist. When you see that word agonist, that means pro, for. Antagonist is against. So adrenergic agonist, just think pro, for. So let's look at the key terms you need to know. Adrenergic agonist. These are drugs that stimulate the adrenergic receptors of the sympathetic nervous system. Remember, that S in sympathetic stands for what? Speeding up, right? Heart rate increase, blood pressure increase. That S stands for speeding up. Alpha agonist. This stimulates the alpha receptors within the sympathetic nervous system. Beta agonist. Stimulating to the beta receptors within the sympathetic nervous system. And glycogenesis. This is the breakdown of stored glucose. And what does it do? It increases the blood glucose levels. Sympathomimetics. They mimic the sympathetic nervous system. So those signs and symptoms, when you see that sympathetic nervous system increase, that's what you're going to see. Now, drug cards, the first drug card I'm going to want for you are going to be the alpha and beta adrenergic agonists. Those drugs that underline, those are the ones that students tend to see the most when it comes to pharmacology questions in regards to this chapter, okay? But make sure you have all of them on your drug card, your dobutamine, your dopamine, ephedrine, epinephrine, norepinephrine. The second drug card I need from you, do I need to make this bigger? Writer. Is that better?
Oh, yeah.
So the three underlines with big words.
The second drug card are going to be the alpha specific adrenergic agonists. Your clonidine, phenylphedrine, those three drugs. The third drug card I need from you are the beta specific adrenergic agonists. Albuterol, formoterol, arformoterol. So for this chapter, I got three drug cards I need from you, okay? All right, let's get started. An adrenergic agonist is also called a sympathomimetic drug because it mimics the effects of the sympathetic nervous system. So when you're thinking about these adrenergic agonists, think of the sympathomimetic drugs. That S, thank you, very good. All right, next page. Adrenergic agonists for children. Children are at greater risk for complications associated with the use of adrenergic agonists, including tachycardia, increased heart rate, hypertension, increased blood pressure, tachypnea, increased respiration, and GI complications. Phenylephrine is often found in over-the-counter allergy and cold preparations, and parents need to be instructed with the careful use of these drugs. They need to always read the labels. They should check labels for ingredients. Adults, we talk about adults in adrenergic agonists. Patients who may be at increased risk for cardiac complications should be monitored closely and started at lower doses because we know that it increases the heart rate, increases the blood pressure. So somebody who already has a cardiac condition, we have to be much, much more careful and start them at a lower dose to prevent those cardiac complications. Adults using these agents for glaucoma or seasonal rhinitis needs to be cautioned about over-the-counter drugs and alternative therapies because it might increase the drug effects. Because remember, these drugs are found in many over-the-counter medications, cough and cold medications. Adrenergic agonists for the older adult. Now we're talking about the geriatric population. Older patients are more likely to experience the adverse effects that are associated with the adrenergic agonist. CNS, cardiovascular, GI, and respiratory complications. Older adults should be started on lower doses. Remember, when it comes to geriatric population, liver's not working the way it used to, so it's not metabolizing the drugs the way it used to. Kidney's not working the way it used to, so they're not excreting the drugs the way they used to. So they are at higher risk for a toxic level of these drugs in the body. And as always, they need to be checking the labels of these over-the-counter medications because lots of these cough and cold medications have these ingredients. Okay? Alpha and beta adrenergic agonists. What did I write here on the side? On the side, I wrote, okay, shock, bronchospasms, asthma. And you'll know why I wrote that in a second. So let's talk about the alpha and beta adrenergic agonists. These drugs are generally sympathomimetic. They're called alpha agonists and beta agonists. The agonist stimulates all of the adrenergic receptors. That is, they affect both the alpha and beta receptors. Agents that affect both the alpha and beta receptor sites include, and they give you that list. Those are the drug cards I just told you I need from you for the alpha and beta adrenergic agonists. Make sure you know them. Therapeutic actions and indications of the alpha and beta adrenergic agonists. Heart rate increases. Respirations increase. Blood pressure increase. But look at this, intraocular pressure decreases. So that's why this is a great medication for glaucoma, because what is glaucoma? It's increased pressure in the eye. Glycogenesis, which is a breakdown of glucose stores, happens. So guess what? Increases the blood glucose in the patient's body. The pupils dilate and sweating increases. These drugs are generally indicated for treatment of hypotensive states. And it makes sense because this drug increases the blood pressure. So if a patient's hypotensive, this is a great medication to give. But you know, if our patient's hypertensive and the doctor orders this medication, are we going to just blindly give it? No, we're going to hold it and call the healthcare provider and say, hey, this patient's blood pressure is already high. Are you sure you want to give it? And they say, yes, you tell them to come down and do it themselves. You're not going to lose your license. Okay, so we give it for hypotensive states or shock, bronchospasms, and some types of asthma. If you remember anything that I'm telling you about these alpha and beta adrenergic agonists, remember shock, bronchospasms, and asthma. Dopamine, a naturally occurring catecholamine, is the sympathomimetic drug of choice for the treatment of shock. Which one's the drug of choice for treatment of shock? Dopamine. Make sure you know it. I'll come back to this box in a second. Actually, no, we'll do it now. Let's look at this box on the bottom, box 30.2, safe medication administration. Administering ophthalmic medications. Some of the adrenergic agonists are applied in the eye. Remember, one of the therapeutic actions for glaucoma, right? So some are given in the eye. It's important to review the technique. First, number one, always number one, wash your hands. You don't want the pathogens that are your hands going into the patient. First, wash your hands thoroughly. And it's not in here, but I'm going to tell you, after you wash your hands, put on gloves. Guys, whenever you expect to come in contact or may possibly come in contact with anything that's wet, any body fluids, put on gloves, whether it's saliva, whether it's vomitus, whether it's urine, whether it's feces, whether it's blood. If it's wet, put on gloves. Wash your hands, put on gloves. Do not touch the dropper to the eye or any other surfaces. We're not trying to transfer bacteria or other pathogens. Have the patient tilt his or her head back and lie down and stare upwards. You're going to instill the prescribed number of drops. Look at this where you put it, guys, in the lower conjunctival sac. Have them close their eyes. You're going to apply gentle pressure. Look where you're applying that gentle pressure to the inside corner of the eye for 3 minutes. If more than one eye drop is being used, you have to wait 5 minutes before you apply the second eye drop. 5 minutes between eye drops. And I've seen this often as put in order with your mouse, where you have to actually put those steps in order. So make sure you know them.
What's written below number one?
Number one, oh, I just put a star next to it. The star. All right, next page, page 507. You guys see this figure, make sure you know it. Make sure you understand the physiological adrenergic effects. What does it do to the eyes? It dilates the pupils. Mouth, decrease salivation, decrease secretions. And it'll make more sense when we talk about, well, let me not get you guys confused, but make sure you guys know this. Respiratory tract, increase respirations, increases depth of respirations. For the cardiovascular system, it increases the pulse, increases vasoconstriction. And think about it. Whenever we have vasoconstriction, what's going to happen to the blood pressure? It's going to increase, right? So increases vasoconstriction, increases blood pressure, increases blood flow to the muscles. What happens to the GI system? It decreases pancreatic secretions. And we know the pancreas is responsible for those enzymes, right? Islets of the beta cells in the islets of Langerhans is where? In the pancreas, right? That controls insulin. So this is how you're supposed to be thinking to figure out what's going on with the body. Decreases gastric secretions, decreases GI motility. When nothing's moving, you get stopped up, right? Constipation. Decreases perfusion. GY. What's that Y stand for? Genital urinary. I don't know why this called it Y, but whatever. Oh, genital urinary, the Y. Okay. It decreases renal blood flow, decreases uterine activity, bladder relaxation, skin, vasoconstriction, patient's skin will look pale, piloerection, increased sweating. Make sure you guys know these physiological effects of the adrenergic system. Table 30.1. Dobutamine is used for treatment of heart failure. Dopamine treats shock. Ephedrine treats hypotensive episodes. Epinephrine, it treats shock when increased blood pressure and heart contractility is very important. It's the primary treatment for bronchospasms. And norepinephrine, it treats shock and it's used during cardiac arrest. Dobutamine, it's used for the treatment of heart failure because it can increase myocardial contractility without much change in the rate, and it does not increase the oxygen demand of the cardiac muscle. Now, that's saying a lot, and you guys have to understand why dobutamine is so important. So it's used primarily for treatment of heart failure. What's going on heart failure? Basically, guys, your heart's supposed to be beating like this. Look at my hands, right? It's supposed to be pushing out all of this oxygenated blood that's supposed to go to all your body, from your brain to the tips of your toes. Look how strongly that heart is beating. But when the patient has CHF, that heart is weak. So they're doing this, and they're not pushing out enough oxygenated blood to go throughout the body, right? So look at what dobutamine does. It increases the contractility. When you see something says it increases the contractility, it does this. It squeezes much better to get all of that oxygenated blood out to the body. So the wonderful thing is dobutamine, it increases the contractility without much change in the rate. That's important because we'll get to that later, but another great medication, no, I'm not going to confuse. Let's just leave it there. You need to know about dobutamine for now. Make sure you understand this, okay? Pharmacokinetics. When used in emergency situations, they're given IV to achieve a rapid onset of action. We know that the fastest route of absorption is IV. It goes directly into the bloodstream. Contraindications and cautions. The alpha and beta agonists are contraindicated in patients that have hypersensitivity. Obviously, if they're allergic to any of those ingredients in the medications, you're not going to give it. Pheochromocytoma, because of the systemic overload of catecholamines. that tumor can produce. Also contraindicated, patients with tachyarrhythmias, if their heart rate is already way over 100, do you think that's a good medication to give them? No. Patients who have VFib, patients with hypovolemia, hydrocarbon general anesthetics, patients who have that in their system. Caution should be exercised with any kind of peripheral vascular disease, such as atherosclerosis, Raynaud's, diabetic enteritis. I pronounced that wrong, but you guys see the word. Okay? Because the sympathomimetic drugs stimulate the SNS, remember everything speeds up, they should be used cautiously during pregnancy and lactation. Adverse effects of the alpha and beta agonists. Adverse effects, arrhythmias. We may want to bring up that heart rate, but if that medication works a little bit too well, we cause them to have an arrhythmia. Hypertension. Patient could have been in a hypovolemic shock or hypovolemic state, but that medication worked a little bit too well. Now we threw them into hypertension. Palpitations, that's when they feel like their heart's about to come out of their chest. Angina, dyspnea related to the effects of the heart and cardiovascular system, nausea, vomiting, constipation. Remember what happens with the GI tract? Everything slows down, right? Headache, sweating, feelings of tension or anxiety, hypokalemia. This is important, guys. Remember, potassium has a very narrow therapeutic range, 3.55, that's it. Anything outside of that can throw that patient into arrhythmias, and this medication already has a risk of throwing a patient into arrhythmia. So we have to be very careful. Hypokalemia can occur. Patients may be present with muscle cramps related to shift in potassium. Drug-drug interactions. Increased effects of TCAs and MAOIs, those are both antidepressant medications, guys. It can occur because of the increased norepinephrine levels. Increased risk of hypertension if alpha and beta adrenergic agonists are given with any other drugs that could cause hypertension. And that makes sense. It will only worsen the effect, including herbal therapies and over-the-counter preparation. So it's very important when you're assessing your patient and asking them what type of medications they're taking. You also need to know anything over-the-counter or herbal therapies. Let's take a look at figure 30.3 on page 508. Again, make sure that you guys know the adverse effects associated with the adrenergic agonist. Respiratory can cause dyspnea, cardiovascular effects, hypertension, arrhythmias, angina, GI effects, constipation, nausea, vomiting. Possible fetal toxicities. We give this very cautiously in anyone that's pregnant, right? Look at box 30.4, herbal and alternative therapies. I'm not reading all of that. The whole point of all of that is to say that these patients need to stay away from over-the-counter drugs and herbal therapies. They need to consult their healthcare provider before they take anything over-the-counter or any herbs. Nursing considerations for the patient taking alpha and beta adrenergic agonists. You're going to assess them for any allergies to the drugs, pheochromocytoma, tachycardias, VFib, hypovolemia, general anesthesia, anesthetics, presence of vascular disease, them being pregnant or breastfeeding. You're going to do a physical assessment on the patient. You always want to get a baseline. You're going to do vital signs, including the respirations and the rate, because we know the effects on the lungs. Monitor urine output. Monitor lab tests such as the liver function test. Remember, it affects the liver and the kidneys. Make sure you're looking at the serum electrolytes, especially what? Potassium, because it can cause hypokalemia. So we're going to be looking at those potassium levels. Can I turn my page? Always dilute a parental drug before use if it's not pre-diluted. You better use aseptic technique when you're administering ophthalmic or nasal agents, which means you're going to wash your hands and put on gloves. Monitor patients receiving drug ophthalmically or nasally for all of the systemic effects that are associated with parental administration. It may be absorbed systemically. You're giving something and you want it to be absorbed locally, but you still have to watch out for those systemic effects. Monitor the patient's response closely, such as a heart rate, the blood pressure. You may have to do an ECG to get a baseline. Maintain Pentolamine on standby. And this is important, guys. This is the medication, those alpha and beta agonists, if it, what's the word I'm looking for? It gets out of the vessel. What's the word I'm looking for? When a blood, not diffuses. Oh my God. Yes, extravasation. When it gets out of the actual vessel and that medication gets to the surrounding tissues, it can cause necrosis of the surrounding tissues. It's very, very harsh. Okay, so this is the drug that we give for that, Pentolamine. Make sure you know it. Make sure you have that drug on standby. Oh, here's the word I was looking for, extravasation. Okay, make sure you have it on standby. Monitor light exposure. Remember pupil dilation, right? Encourage the patient to avoid before giving the drug. Remember, it can cause urinary retention. Monitor the bowel function. It can cause constipation. And you're going to teach the patient the following. You're going to teach them about their medication. You're going to teach them about the side effects, the adverse effects. You're going to teach them warning signs. You're going to teach them to read the label of anything that they take. Make sure you guys take a look at everything you're going to teach the patient. Okay, here's a case study. I'm not reading all of this, but I'm going to tell you the point of it. So a patient has been ordered ephedrine. Okay, what are you going to say to the patient? You're going to tell them that this is an adrenergic agonist, also known as a sympathomimetic drug. Ephedrine acts by mimicking the effects of the sympathetic nervous system. Remember your fight or flight response? You're going to teach them if the drug's in the solution, check it before each use. If the solution is pink, brown, or black, discard it. If you have been diagnosed with prostate problems, it might help to avoid before taking each dose of the drug because it can possibly cause urinary retention, and prostate problems will make that even worse, right? Teach them the adverse effects, such as restlessness or shaking. If they have restlessness or shaking, avoid driving or operating heavy machinery. Flushing or sweating. For flushing or sweating, avoid warm temperatures. Avoid heavy clothing. Frequent washing with cool water can help. What about heart palpitations? If they feel like their heart's coming out of their chest, teach them to sit down for a while and rest. Sensitivity to light. Remember that pupil dilation that can happen. So teach them to avoid glaring lights or wear sunglasses. Teach them to report the following to the healthcare provider: difficulty voiding, chest pain, difficulty breathing, dizziness, headache, or changes in vision. Do not stop taking this medication abruptly. You need to be weaned off. Avoid over-the-counter medications, including cold and allergy remedies and diet pills. You know diet pills increase your heart rate, right? Okay. Do not share this drug with anyone else. It's been prescribed to you. All right, let's move on to alpha-specific adrenergic agonists. So we went to both, we were talking about both the alpha and beta, but now we're talking about the alpha-specific adrenergic agonists. Alpha-specific adrenergic agonists or alpha agonists are drugs that bind primarily to alpha receptors rather than to beta receptors. Phenylephrine a potent vasoconstrictor and alpha agonist with little or no effect on the heart or bronchi is used in many combination in cold and allergy products. So again, we're going to be teaching those patients to look at ingredients of those over-the-counter medications. Parentally, it's used to treat shock or shock-like states, to overcome paroxysmal SVT, to prolong local anesthesia, and to maintain blood pressure during spinal anesthesia. Topically, it's used to treat allergic rhinitis and to relieve symptoms of otitis media, that's an ear infection. Ophthalmically, it's used to dilate the pupils for eye examination before surgery or to relieve elevated eye pressure that's associated with glaucoma. Phenylephrine is found, this is the second time they're telling us this, guys. Phenylephrine is found in many cold and allergy products because it's so effective in constricting topical vessels and decreasing the swelling and signs and symptoms of rhinitis. So the patients need to look at those labels. Midodrine is an oral drug that's used to treat orthostatic hypotension in patients who do not respond to traditional therapy. So this just told us something. This is not our first go-to, right? The midodrine we give when the patient hasn't responded to traditional therapy. It can cause serious supine hypertension. Patients need to be monitored standing, sitting, and supine position. We better be checking their blood pressure because it can cause supine hypertension. Here it says it treats orthostatic hypotension, but again, guys, whenever we're giving a medication, you always have to think about what happens if it works a little bit too well. We might get that blood pressure to go too high. Clonidine. Clonidine is used to control hypertension and as an injection for epidural infusion to control pain in cancer patients. Clonidine is associated with many more CNS effects such as bad dreams, sedation, drowsiness, fatigue, headache, and other sympathomimetic effects such as, the tachycardia, the tachypnea, the hypertension. It can also cause extreme hypertension, heart failure, and bradycardia due to its decreased effect on the sympathetic outflow from the CNS. Now, before I move on, I want you guys to take a look at table 30.2. Clonidine. The indications, what we treat for essential hypertension, to ease opiate withdrawal, and it's used only in adults. Midodrine, it treats orthostatic hypotension. Phenylephrine, excuse me, treats cold and allergies, shock and shock-like states, SVTs, glaucoma, allergic rhinitis, and otitis media. Contraindications and cautions of the alpha-specific adrenergic agonist. Allergies, if they're allergic to any portion of the drug, if they have severe hypertension or tachycardia or narrow angle glaucoma, pregnancy, lactation. Cardiovascular disease or vasomotor spasm, thyrotoxicosis, diabetes, kidney or liver disease. Adverse effects. Adverse effects include feelings of anxiety, restlessness, depression, personality changes, cardiovascular effects, arrhythmias, ECG changes, blood pressure changes. GU effects, decreased urinary output, difficulty urinating, dysuria. These drugs should not be stopped suddenly. Patient must be weaned off. Sudden withdrawal can lead to tachycardia, hypertension, arrhythmias, flushing, and even death. If phenylephrine is given IV, care should be taken to avoid extravasation. It can cause necrosis of the surrounding tissue. The vasoconstricting effects of the drug can lead to necrosis and cell death in the area of the extravasation. So what are we going to have on hand? What does it start with? Thank you. I'm not going to try to pronounce that drug. Pentolamine. I can't pronounce yet. Pentolamine. 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 Make sure you have that on hand. All right, drug-drug interactions. Phenylephrine combined with MAOIs can cause severe hypertension, headache, and hyperpyrexia. This combination should be avoided. Increased sympathomimetic effects occur when phenylephrine is combined with TCAs. That's another type of antidepressant. Clonidine. Clonidine has a decreased antihypertensive effect if it's taken with TCAs. A paradoxical hypertension occurs if it's combined with propranolol. And that is paradoxical. Whenever you see that word paradoxical, that means the opposite. That means, what's the word I'm looking for?
The opposite is what's the therapy?
Yes, the opposite, but there's another word I'm looking for. It'll come to me. But you know how if something, you expect something to go down and it goes up, or vice versa. Ironic, that's the word I'm looking for, ironic. Ironically, because this medication is really supposed to bring that blood pressure down, right? But ironically, if it's given it with propranolol, which brings down blood pressure, it does the opposite. It brings up the blood pressure. Okay. Midodrine can precipitate increased drug effects of digoxin, beta blockers, and many antipsychotics. That combination should be avoided. Any adrenergic agonist will lose its effectiveness if it's combined with the adrenergic antagonist. And that makes sense. Why would you give an agonist and an antagonist at the same time? It makes no sense. All right. Nursing considerations for the patient taking alpha-specific adrenergic agonists. You're going to assess them for contraindications such as allergies, cardiovascular disease, thyrotoxicosis or diabetes, renal failure, liver failure, pregnancy, lactation. You're going to make sure you do a physical assessment on the patient. You're going to get a baseline, assess them for orientation. You may do an ECG at the beginning to get a baseline on that patient because remember, it has effects on the cardiovascular system. Assess the urinary output because it can cause urinary retention. Evaluate them for nausea or constipation. You're going to make sure you're looking at lab results. Implementation rationale. Do not discontinue the drug abruptly. Drug must be tapered over 2 to 4 days. Do not discontinue the drug before surgery. Mark on the patient's chart and monitor their blood pressure carefully. Monitor blood pressure, orthostatic blood pressure, pulse, rhythm, cardiac output. When giving phenylephrine IV, ensure that an alpha blocking agent is readily available to counteract the effects. Pentolamine should be given within 12 hours after extravasation, preferably immediately. You're going to provide comfort measures, have the patient rest, environmental control, make sure there's dim lighting, analgesics for any headaches. You're going to provide safety measures, teach the patient if they need to get up to press a call button so you can walk with them. We don't want any falls, make sure the side rails are up. Make sure they have readily access to the restroom. Teach them not to operate heavy machinery. All right, let's talk about the beta-specific adrenergic agonists. Most of the drugs that belong to this class, excuse me, to the class of beta-specific adrenergic agonists or beta agonists are the beta-specific agonists that are used to manage and treat bronchial spasm, asthma, and other obstructive pulmonary conditions. They give you the list. You guys are going to get that to me on my drug cards next week. Before we get to the therapeutic actions and indications, I put a star next to the ones that are seen most on test. So make sure you know them. Albuterol, levobuterol, salmeterol, terbutaline. Make sure you know them, okay? Therapeutic actions and indications. Therapeutic effects of isoproterenol are related to its stimulation of all beta adrenergic receptors. Desired effects of the drug include increased heart rate, increased conductivity, increased contractility, bronchodilation, increased blood flow to skeletal muscles, and splenic beds, and relaxation of the uterus. That's what we want to see happen. Contraindications and cautions. Isoproterenol is contraindicated in the presence of allergy, pulmonary hypertension, anesthesia with halogenic hydrocarbons, eclampsia, uterine hemorrhage, intrauterine death, pregnancy, lactation. Caution should be exercised in patients with diabetes, thyroid disease, vasomotor spasms, degenerative heart disease, history of stroke, severe kidney or renal impairment. Adverse effects. The CNS effects include anxiety, tremor, fatigue, cardiovascular effects, tachycardia, angina, MI, palpitations. Pulmonary effects, difficulty breathing, coughing, bronchospasms, severe pulmonary edema. GI upset, nausea, vomiting, anorexia can occur. Hypokalemia, that's a biggie. Potassium has a very narrow therapeutic range, 3.5 to 5, that's it. So we have to be careful because it adverse affects hypokalemia. Other anticipated effects, sweating, pupil dilation, muscle cramps, rash. Let's talk about the nursing considerations for patients receiving beta-specific adrenergic agonists. We're going to assess them for allergies, pulmonary hypertension. By the way, these are contraindications, guys. Anesthesia with halogenated hydrocarbons, eclampsia, uterine hemorrhage, intrauterine death, diabetes, thyroid disease, vasomotor spasm, degenerative heart disease, history of stroke, renal or liver impairment, pregnancy, lactation. You're going to do a physical assessment on the patient. You're going to assess their cardiovascular status, including the pulse, blood pressure, do an ECG to get the baseline. You're going to assess the respiratory status and listen for adventitious lung sounds. That word adventitious doesn't mean good or bad. Bad, yeah. We're not trying to hear crackles or rails or stridor or wheezing. All of those are bad. We want clear lung sounds. Monitor urine output, monitor lab results. Implementation rationale. You're going to monitor patient blood pressure and pulse. Ensure that a beta adrenergic blocker is readily available when giving parenteral isoproterenol. Use minimal doses of isoproterenol needed to achieve desired effects. You're going to provide the patient with rest and environmental control, analgesics as needed for headache, safety, side rails up, teach them not to get up without assistance. Avoid overhydration, because one of the adverse effects that can happen, guys, remember pulmonary, what is it? What's the word I'm looking for? Pulmonary hypertension, but that's not the one I'm looking for. I'm having a brain. Are you guys awake? I'm having a brain fart. You guys can't be having a brain fart with me.
It says avoid overhydration and pulmonary edema.
Pulmonary edema, thank you. That's the word I'm looking for, edema. Oh, it was right here. Nice. All right. Summary, read that on your own. That summary is everything we just gone over. Take 5 minutes to stretch, use the restroom, and then we will continue with chapter 31. Because you guys are clocking out on me. It's too soon for that. Oh, you knew you were going to get 10.
No, because the last week was 5.
You guys are killing me. All right. Fourth drug card, the non-selective adrenergic blocking agents, amiodarone, carvedilol, and labetalol. Drug card number 5, non-selective alpha adrenergic blocking agents, Pentolamine. Number 6, the 6th drug card I need from you, non-selective beta adrenergic blocking agents. You see that list: propranolol, sotalol, timolol. Number 7, the 7th drug card, the beta selective adrenergic blocking agents, atenolol, betaxolol. You see that whole list. So that's 7 drug cards. You guys are up to 7. Okay. All right. So we were talking about agonists, right? Now we're talking about antagonists. So everything we just learned is the opposite. We're moving in the opposite direction. So if you know one, you should know the other. So we're going to talk about adrenergic antagonists or adrenergic blocking agents. These are also called sympatholytic drugs because they lyse or block the effects of the sympathetic nervous system. So guys, study harder, not smarter. No, study smarter, not harder. Study smarter, not harder. All right, let's talk about the non-selective adrenergic blocking agents. These are drugs that block both the alpha and beta adrenergic receptors, and they're primarily used to treat cardiac-related conditions. These drugs include, those are your amiodarone, carvedilol, labetalol. Therapeutic actions and indications. Remember how everything was up because it was pushing the sympathetic nervous system, right? Blood pressure up, heart rate up, respirations up. Look at what's happening now. These antagonists, again, they lower the blood pressure. They slower the heart rate. They increase renal perfusion with decreased renin levels. So these patients are going to be what? We expect them to be urinating more, right? Most of these drugs are indicated to treat essential hypertension alone or in combination with diuretics. Labetalol is used intravenously and orally to treat hypertension. Amiodarone, which is available in the oral and IV form, is saved for serious emergencies and only used as an antidysrhythmic. Carvedilol is available orally and is used to treat hypertension as well as heart failure and left ventricular dysfunction after an MI. Make sure you guys take a look at figure 31.1 and look to see what the adrenergic blocking agents do. Look, the pupils do not dilate like they did with the agonists. Increased GI secretions. Remember, with the agonist, it was decreased. Loss of bronchodilation. Decreased venous return related to vasodilation. You guys see it's the opposite, guys. Increased GI activity, decreased glucose regulation, relaxed sphincters to increase GI excretions, relaxed sphincters to increase urine flow, where before we were worried about urinary retention. If you know one, you should know the other. All right. Let's look at this box for adrenergic blocking agents for the child. Children are at greatest risk for complications, including bradycardia, difficulty breathing, changes in glucose metabolism. Prazosin is used to treat hypertension, and Pentolamine, which is used during surgery for pheochromocytoma. Adults, this is important. This has been seen on NCLEX many times. Make sure you know this. Patients with diabetes needs to be re-educated about ways to monitor themselves for hyperglycemia and hypoglycemia, because the sympathetic reaction, such as sweating, feeling tense, increased heart rate, rapid breathing, which usually alerts patients that there's a problem with their glucose levels, we don't see it, or it's diminished. Patients with severe thyroid disease are also at risk for serious adverse effects when taking these drugs. Let's talk about the geriatric patient. Because older patients often also have renal or hepatic impairment, they're more likely to have toxic levels of the drug. Remember, kidney, liver's not functioning the way it used to, so they're going to be holding on to the med more. The older patient should be started on lower doses of the drug and should be monitored closely for potentially serious arrhythmias or blood pressure changes. Bisoprolol is often a drug of choice, ding, 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 drug of choice for older patients who require an adrenergic blocker for hypertension. Box 31.2, herbal and alternative therapies. You guys read this on your own, but guess what? All of these herbal therapies, patients shouldn't be taking while they're on adrenergic blockers. The ginseng, saw palmetto, I can't even pronounce half of them. Tell the patient to avoid them. Patients who are prescribed an adrenergic blocking drug should be cautioned about the use of herbs, teas, and alternative medicines. If a patient feels that one of the agents is needed, the healthcare provider should be consulted first. Contraindications and cautions for the adrenergic blocking agents. We're going to assess them for any hypersensitivity, allergy, bradycardia or heart block, asthma. I put a star next to asthma, NCLEX next to asthma. Make sure you know that. That is a contraindication. Shock, heart failure complications. Contraindication, excuse me. The drug should be used with caution in patients with diabetes. Why? Because the disorder can be aggravated by the blocked sympathetic response, and because the usual signs and symptoms of hypoglycemia and hyperglycemia are masked with the SNS blockade. They block those signs and symptoms of the sympathetic nervous system. Caution should also be exercised in patients with bronchospasms, pregnancy, lactation. Adverse effects: dizziness, paresthesia, insomnia, depression, fatigue, vertigo, nausea, vomiting, diarrhea, anorexia, flatulence. Cardiac arrhythmias, hypotension, heart failure, pulmonary edema, CVA, stroke, bronchospasms, cough, rhinitis, bronchial obstruction. Other adverse effects: decreased exercise tolerance, hypoglycemia, rash. Abruptly stopping these drugs after long-term therapy can cause a myocardial infarction, stroke, and arrhythmia. Carvedilol has been associated with hepatic failure. So we're definitely going to be looking at the liver function test studies before the patient's on that medication, right? We need that baseline. Abruptly stopping these drugs after long-term therapy can result in myocardial infarction, stroke, and arrhythmias related to the increased hypersensitivity of catecholamines that develop when receptor sites have been blocked. The author just told us the same thing back to back. Don't you think that's important to know? Yes. What did I write here? I wrote, do bedside EKG if the patient stops suddenly. Okay. This is what I meant. So you're expected to do an EKG at the bedside if that patient has been on these meds and then they suddenly stop, or maybe they come in, you're working in the doctor's office and they're like, what, I just stopped taking that medication because I wasn't feeling well. We're going to do an EKG immediately, especially if they're symptomatic. Drug-drug interactions. The effectiveness of diabetic agents is increased, leading to hypoglycemia when such agents are used with these drugs. So those anti-hyperglycemic drugs start working a little bit too well. Next page, make sure you guys know figure 31.2. Know these adverse effects, such as on the CNS, patients going to have dizziness, paresthesia, fatigue. Respiratory effects, they may have cough or bronchospasm. Cardiovascular effects, we're going to be looking out for heart failure, arrhythmias, hypotension. GI effects, we're going to be looking out for nausea, vomiting, flatulence. Nursing considerations for the patient taking non-selective adrenergic blocking agents. We're going to assess them for contraindications such as allergies to the medication, the presence of bradycardia or heart block, or asthma, or bronchospasms, or shock, or heart failure, diabetes, pregnancy, lactation. We're going to do a physical assessment on the patient. We need to get a baseline on them. We're going to assess their level of orientation. We're going to assess them for any dizziness, paresthesia, vertigo, which are adverse effects. So we're going to assess them at the beginning. We're going to get an ECG as ordered to get baseline. Assess their respiratory rate and auscultate the lungs. Observe for ease of breathing. Report any signs and symptoms of bronchospasm or respiratory distress. You see, I put a star next to it. That's important. Make sure you know it. Monitor GI activity. We're going to be looking at the lab tests. We're going to be looking at the LFTs. We're going to be looking at the BUN, the creatinine, the GFR. We're going to be looking at the blood glucose. Implementation rationale. Do not discontinue abruptly after chronic therapy. It must be tapered slowly over 2 weeks. Monitor the heart rate and blood pressure as tapering. Consult the physician about withdrawing the drug before surgery. Teach a patient about lifestyle changes, exercise, smoking cessation, stress reduction. You're going to assess their heart rate, take their blood pressure, teach them safety precautions, teach them to move slowly to prevent hypotension, monitor GI function, monitor for any signs of liver failure. Again, teach them to change position, avoid operating heavy machinery. Okay, we're going to move on to non-selective alpha adrenergic blocking agents. Only one of these drugs, Pentolamine, is still used as the non-selective alpha adrenergic blocking agent. So that drug card should not be too hard for you guys to give me. Therapeutic actions and indications. What we want to see happen is lowering of blood pressure. Pentolamine is most frequently used to prevent cell death and tissue sloughing after extravasation of IV norepinephrine and dopamine. Remember? Okay. It causes a local vasodilation and a return of blood flow to the area. Contraindications and cautions: allergy, presence of coronary artery disease or MI, pregnancy, breastfeeding. Adverse effects: hypotension. If they're already hypotensive, would that be a good drug to give them? No. Orthostatic hypotension, angina, MI, CVA, flushing, tachycardia, arrhythmia. Headache, weakness, dizziness can occur in response to the hypotension that it causes. Nausea, vomiting, and diarrhea can also occur. drug-drug interactions. Ephedrine and epinephrine may have decreased hypertensive and vasoconstrictive effects if they're taken at the same time with pentolamine. And that makes sense, guys, because they do the opposite job. Increased hypotension may occur if the drugs combined with alcohol, which also is a vasodilator. Nursing considerations for the patient taking non-selective alpha adrenergic blocking agents. We're going to assess them for contraindications such as allergies, cardiovascular disease, pregnancy and lactation. We're going to do a physical assessment on the patient. We're going to assess their orientation, affect, reflexes, implementation rationale. Monitor the heart rate and blood pressure closely and frequently. This is important. Inject pentolamine directly into the area of extravasation if epinephrine or dopamine has happened. Provide rest, environmental control, analgesics for headache. Teach them safety measures. Okay, we're moving on to alpha selective adrenergic blocking agents. Therapeutic actions. They cause a decrease in the vascular tone and vasodilation. And that vasodilation leads to a fall in blood pressure. Causes reflex tachycardia that accompanies a fall in blood pressure. Let me read that again. Because these drugs do not block the sympathetic alpha receptor sites, the reflex tachycardia that accompanies a fall in blood pressure does not occur. So we see normally what's supposed to happen, guys, when the blood pressure goes down, right, the heart rate is supposed to increase, because what happens is brain says heart says yes, brain says we're in trouble, heart says what you want me to do, and brain says you need to speed up. Why? Because if that blood pressure is low, that means that body's not being perfused. So your body's going to try to save itself no matter what. So what we expect to happen when the blood pressure goes down, we expect to see that heart rate go up because it's trying to compensate. It's trying to push all of that oxygenated blood to the body. That's what's normally supposed to happen. But look at what they're saying here. Because the drugs do not block the presynaptic alpha receptor sites, the reflex tachycardia that we normally see in hypotension does not occur with these drugs. Okay? They also block smooth muscle receptors in the prostate, prostatic capsule, prostatic urethra, and urinary bladder neck, which leads to relaxation of the bladder and prostate. The bladder relaxes, the prostate relaxes, urine flows increase. These drugs are available in oral form and can be used to treat BPH, benign prostatic hypertrophy, and hypertension because of the vasodilation, which brings down that blood pressure. Contraindications and cautions: any allergy, lactation, heart failure, renal failure, hepatic impairment, pregnancy. Adverse effects of alpha-selective adrenergic blocking agents. These adverse effects associated with the use of the drugs are usually related to their effect on the SNS blockage. Remember, they're antagonists. CNS effects: headache, dizziness, weakness, fatigue, drowsiness, depression. Nausea, vomiting, abdominal pain, diarrhea can occur. Cardiovascular effects: arrhythmias, hypotension, edema, heart failure. The vasodilation caused by these drugs can cause flushing, rhinitis, reddened eyes, nasal congestion, retrograde ejaculation, and priapism. Drug-drug interactions. Increased hypotensive effects can occur if these drugs are combined with any other vasodilating or antihypertensive drugs, which makes sense. Let's stop there for a second. This drug itself brings down the pressure. It causes vasodilation. So it makes sense if you give it with another drug that does the same thing, you can cause that patient have a hypotensive crisis. They're giving you guys examples. Look at those examples. Nitrates, calcium channel blockers, drugs used for erectile dysfunction. Think about it. How is the man able to get a, well, all the blood in their system goes down here, and that's what causes this. So if all of the blood is here, their system, they're going to have what? Hypotension. Okay, so it makes sense. ACE inhibitors. Usually, this is seen as a select all that applies. Make sure you know it. Before I go into the nursing considerations, look at these drugs on table 31.3. Doxazosin treats hypertension BPH. Tamsulosin, that's the Flomax, treatment of BPH. Terazosin, treatment of hypertension and BPH. All right, nursing considerations for patients receiving alpha-selective adrenergic blocking agents. We're going to assess them for contraindications such as allergy, heart failure, renal failure, hepatic dysfunction, pregnancy, lactation. We're going to do a physical assessment on the patient. We're going to monitor their level of orientation. We're going to do vital signs, including listening to the heart and lungs. We're going to check the cardiac output. We're going to check peripheral perfusion. We're going to do an ECG. We need a baseline on the patient. Assess renal function, including urinary output. Monitor for renal and hepatic function. Implementation rationale. We're going to monitor the blood pressure, pulse, rhythm, cardiac output regularly. Establish safety precautions. For a GI upset, you're going to teach them small, frequent meals, rest, environmental control, safety measures. Teach them to change position slowly. Avoid driving or operating heavy machinery. Report the use of any other drugs, including drugs for erectile dysfunction, and dietary measures in conjunction with drug therapy. Non-selective beta adrenergic blocking agents. The beta adrenergic blocking agents are used to treat migraine headaches and cardiovascular problems and to prevent reinfarction of MI. So the patient already had an MI once. It's used to prevent it from happening again. Therapeutic actions and indications. For the non-selective beta adrenergic blocking agents, decrease heart rate, contractility, and excitability. Decrease arrhythmias, decrease cardiac workload, decrease oxygen consumption. The higher your oxygen demand is, the harder that your heart would have to work. It treats hypertension and chronic angina and can help prevent reinfarction after an MI by decreasing the cardiac workload and oxygen consumption. So it makes the heart not have to work as hard because the body doesn't need as much oxygen. Sotalol is used exclusively for treating life-threatening ventricular arrhythmias and to maintain sinus rhythm in patients with atrial flutter or AFib. Propranolol is effective in blocking all of the beta receptors in the SNS and was one of the first drugs of this class. Contraindications and cautions of the non-selective beta adrenergic blocking agents. Allergy, bradycardia or heart block, shock, heart failure, bronchospasm, COPD, acute asthma, pregnancy, lactation. These drugs should be used cautiously in patients with diabetes and hypoglycemia. I put star next to it. It's been seen on NCLEX. Make sure that you know this. Other contraindications, thyrotoxicosis, renal hepatic dysfunction. Adverse effects. For the CNS, headache, fatigue, dizziness, depression, sleep disturbances. Cardiovascular effects, bradycardia, heart block, heart failure, hypotension. Pulmonary effects, severe pulmonary edema, bronchospasm, coughing. The list goes on, guys. If you have that list, take a look at it. I'm going to jump down here. Other effects can include decreased exercise tolerance, hypoglycemia or hyperglycemia, liver changes. If these drugs are stopped abruptly after long-term use, there's a risk of angina, myocardial infarction, hypertension, and stroke. Drug-drug interactions. A paradoxical hypertension occurs when both beta blockers are given with clonidine. And that's so ironic because beta blockers and clonidine is supposed to bring the blood pressure down. Okay. So paradoxical hypertension can occur when we're giving them with beta blockers or clonidine, and an increased rebound hypertension with clonidine withdrawal can also occur. A decreased antihypertensive effect occurs when the beta blockers are given with NSAIDs. That's important to know. That's been seen on NCLEX before. Make sure you know that. A decreased antihypertensive effect has been seen when the beta blockers are given with NSAIDs. So that patient's blood pressure is high and you're giving them something, bring down that blood pressure. That patient's also taking an NSAID. It may not work. When this combination is used, the patient needs to be monitored closely. When these drugs are given with insulin or other anti-diabetic agents, there's a potential for change in blood glucose levels. The patient will not display the usual signs and symptoms of hypo or hyperglycemia. Nursing considerations for the patient on non-selective beta adrenergic blocking agents. We're going to assess them for contraindications and cautions such as allergy, bradycardia, heart block, shock, heart failure, bronchospasm, COPD, acute asthma, diabetes, hypoglycemia, thyrotoxicosis, kidney or liver dysfunction, pregnancy, lactation. Again, we're going to do a physical assessment on the patient. We're going to assess their level of orientation. We're going to check their cardiopulmonary status. We're going to monitor GI effects. Make sure you listen to those bowel sounds. We're going to be looking at lab results. Implementation rationale. Do not stop the drugs abruptly after chronic therapy. It has to be tapered over to what? Not 2 hours, 2 weeks. Continuously monitor any patient receiving IV form of these drugs. You're going to monitor the blood pressure, pulse, rhythm, cardiac output regularly. Provide rest and environmental controls. For GI effects, teach them to eat small, frequent meals. Teach them not to drive or operate heavy machinery if they have CNS effects such as dizziness, drowsiness. Okay, so this case study, let's see the patient's on. Okay, so this patient's been prescribed propranolol. I'm on page 534. You're going to teach that patient that's on propranolol. You're going to teach them that propranolol is a beta adrenergic blocking agent, and it works to prevent certain stimulating activities that occur normally in the body when the body comes against a certain type of stress or injury or excitement. Teach them to learn to take their pulse and monitor it daily. Never discontinue that medication abruptly. The drug needs to be tapered over time, 2 weeks. Adverse effects that can occur and what they should do about it. Fatigue or weakness, teach them to stagger their activities, allow rest periods. For dizziness or drowsiness, avoid driving or operating heavy machinery. For change in sexual function, be assured that this is a drug effect and just discuss it with your healthcare provider. Don't stop taking this medication abruptly. Talk to your healthcare provider about it. Nausea, diarrhea, small frequent meals, dreams, confusion, If they become too uncomfortable, discuss it with your healthcare provider. But again, don't stop taking the drug abruptly. Report any of these to the healthcare provider. Very slow pulse. Pulse is supposed to be 60 to 100, right? Anything lower than 60, report. Very slow pulse. Need to sleep on more pillows at night. Anytime a patient has difficulty breathing, guys, the first thing you're always going to do is elevate the head of the bed. Immediately, when you elevate the head of the bed, you're taking pressure, that pressure the diaphragm had against the lungs, you're relieving that pressure so that the lungs can expand so the patient can breathe better. So if the patient finds that they're needing more pillows to sleep at night, what is that really telling you? They may be having lung issues, respiratory issues, right? So reporting they need more pillows at night to sleep. They're having difficulty breathing, swelling in the ankles or fingers, sudden weight gain, mental confusion or personality change, rash, fever. Teach them to avoid over-the-counter medications and herbal therapies. All right, we're moving on to beta-selective adrenergic blocking agents. Beta-selective adrenergic blocking agents. Because they don't usually block beta receptor sites, they do not block the sympathetic bronchodilation that's important for patients with lung diseases or allergic rhinitis. Consequently, these drugs are preferred for patients who smoke or who have asthma or any other obstructive pulmonary disease or seasonal allergic rhinitis. Make sure you know your beta-selective adrenergic blocking agents. Those are one of the drug cards you will be giving me. Therapeutic actions and indications. They do not prevent sympathetic bronchodilation. Decrease heart rate, contractility, excitability. They lead to a decrease in arrhythmias, decreased cardiac workload, and decreased oxygen consumption. All are wonderful for the heart. The heart doesn't have to work as hard. It decreases blood pressure. These drugs are useful in treating cardiac arrhythmias, hypertension, chronic angina, and can help prevent reinfarction after an MI by decreasing the cardiac workload and the oxygen consumption. Beta-selective adrenergic blocking agents in ophthalmic form are used to decrease the intraocular pressure and to treat open angle glaucoma. Make sure you guys know atenolol treats treatment of MI, chronic angina, hypertension. Metoprolol, treatment of hypertension, prevention of reinfarction after MI. Contraindications and cautions. We're going to assess them for allergy, sinus Brady, heart block, cardiogenic shock, heart failure, hypotension, pregnancy, lactation. They should be used with caution in patients with diabetes, thyroid disease, or COPD. Adverse effects for CNS, headache, fatigue, dizziness, depression, cardiovascular effects, bradycardia, heart failure, heart block, hypotension, pulmonary effects, bronchospasm, dyspnea. If these drugs are stopped abruptly after long-term use, again, there's a risk of severe hypertension, angina, MI, and stroke. Drug-drug interactions. We're seeing this again, guys. A decreased hypertensive effect occurs if these drugs are given with clonidine, NSAIDs, rifampin, or barbiturates. At first, look at this. There's an initial hypertensive episode. The blood pressure goes up, followed by bradycardia, slowing of the heart rate if these drugs are given with epinephrine. The selective Beta-1 blockers have increased effects. They're taken if they're taken with verapamil, cimetidine, methimazole, and PTU. Nursing considerations. Before I get into this, so let me just say this to you guys. You have your beta-1 and your beta-2. You guys learned about this in the AMP. And here's a way to remember, just in case you get confused. You have one heart and two lungs. So with that beta-1, it works primarily on the heart, and the beta-2, the lungs. Okay? Anyway, so nursing considerations. We're going to assess them for contraindications or cautions, such as allergies, bradycardia, heart block, shock, heart failure, COPD, current status of pregnancy or lactation. We're going to do a physical assessment on the patient, assess their neurological status, cardiac status. Examine their abdomen. We're going to check the bowel sounds, check the urine output. We're going to be looking at the lab results. Implementation rationale. Do not stop these drugs abruptly after chronic therapy. They have to be tapered off over 2 weeks. Long-term use of these drugs can sensitize the myocardium to catecholamines. Remember, those catecholamines are released whenever the body's stressed, whether it's a physical stress or a psychological stress. Consult with the physician about discontinuing the drugs before surgery. Give oral forms of metoprolol with food. Provide supportive care and comfort measures, rest, environmental controls. Teach a patient to change position slowly and avoid operating heavy machinery or driving. Okay, guys, take 5 minutes, and then we're going to talk about the cholinergic agonists. All right, cholinergic agonists. Cholinergic agonists act at the same site of the neurotransmitter acetylcholine and increase activity of the acetylcholine receptor sites throughout the body. These drugs are often called parasympathomimetics because their action mimics the action of the parasympathetic nervous system. You have direct and indirect. So the direct acting cholinergic agonists occupy receptor sites for acetylcholine on the membranes of the effector cells, causing increased stimulation of cholinergic receptors. In contrast, the indirect cholinergic agonist causes increased stimulation of acetylcholine receptor cells by reacting with the enzyme cholinesterase and prevents it from breaking down the acetylcholine that was released from the nerve. So the first one we're going to talk about are the direct acting cholinergic agonists. They're used as systemic agents to increase bladder tone, urinary excretion, GI secretions, and as ophthalmic agents to induce meiosis to relieve the increased intraocular pressure of glaucoma. Systemic absorption does not occur when these drugs are used ophthalmically. Oh my goodness, nobody was going to remind me about your drug cards? Number 8, the 8th drug card I need from you. I know. Number 8, I need direct acting cholinergic agonists such as bethanechol, carbachol, pilocarpine. That is a very important one. Number 9, the 9th drug card I need is your indirect cholinergic agonist. These are agents that treat Myasthenia Gravis. You see those 3. Adrenergic. Number 10, agents to treat Alzheimer's disease. Donepezil. Okay, so you have my 10 drug cards that you owe me next week, okay? Make sure you guys know these key terms. Acetylcholinesterase. They break down acetylcholine and they prevent overstimulation of cholinergic receptor sites. Alzheimer's disease. This is a degenerative disease with the loss of acetylcholine producing cells, and it's progressive. The dementia gets progressive. That means as time goes on, it gets worse. There is no cure. Cholinergic agonist responds to acetylcholine. Meiosis, constriction of the pupil. Now, this term isn't here, but I wrote it down because NCLEX asked you about it, so you need to know the difference between meiosis and mydriasis. That D in mydriasis stands for dilation. It dilates the pupil, okay? Myasthenia gravis, this is an autoimmune disease where the antibodies to cholinergic receptor sites leads to destruction of the receptor sites. Myasthenia gravis also is progressive. As time goes on, it only gets worse. It's a progressive, debilitating disease leading to paralysis. Parasympathomimetic mimics the effects of the parasympathetic nervous system, which leads to bradycardia, hypotension, pupil constriction, increased GI secretions activity, increased bladder tone, relaxation of the sphincters, and bronchoconstriction. Make sure you guys know those terms. Now I can continue. Where was I? I was talking about the direct acting cholinergic agonist. Okay. So the direct acting cholinergic agonist, excuse me, they increase bladder tone, urinary excretion, GI secretions, and as ophthalmic agents, they induce meiosis to relieve the increased intraocular pressure of glaucoma. We don't see systemic absorption with them, okay? Take a look at figure 32.1. Pharmacodynamics of cholinergic drugs and associated physiological responses. So with the cholinergic drugs, we see pupil constriction. Remember, that's the meiosis. Increased lacrimal secretions, increased salivation, increased secretions, decreased heart rate, decreased contractility, decreased conduction, sphincter relaxation, increased muscle contraction. So make sure you guys understand what these cholinergic agonists do. And you guys are going to look out because for your test next week, because I'm going to stop here on chapter 32. I'm not going to do 33. So yeah, you lucked out. All right, let's talk about the cholinergic agonist for children. It can cause GI upset, diarrhea, increased salivation. That can lead to choking. Loss of bowel and bladder control, a problem that could be a stress in children. So just a little something you guys can remember. I'm not going to talk about the antagonist. We're going to go over that next week. But with the antagonist, the cholinergic antagonist, you guys can remember the still poem, can't see, can't spit, can't pee, can't, right? Can't see, they have that decreased vision, blurred vision. Can't spit, why? Because their mouth is so dry. Can't see, can't spit, can't pee, decreased urination, they're holding on to their urine, can't, constipation. So those are anti-cholinergics. Your cholinergic agonist would be the opposite, right? Okay. Bethenacol is approved for the treatment of neurogenic bladder in children older than 8 years old. Neostigmine and pyridostigmine are used to control myasthenia gravis and for reversal of neuromuscular junction blockage in children. Idofrenium is used for the diagnosis of myasthenia gravis only. We'll talk about that drug in a second. All right, let's talk about the therapeutic actions and indications of cholinergic agonists. They slow down the heart rate, decrease myocardial contractility. They cause vasodilation, bronchoconstriction, increase bronchial mucus secretion, increase GI activity and secretion, increase bladder tone. relaxation of the GI and bladder sphincters. And so that's why it's distressing in children. Children have been potty trained, now all of a sudden they're going on themselves again, right? And pupil constriction, that meiosis. Table 32.1, direct acting cholinergic agonist. Methanocol, treatment of non-obstructive post-op and postpartum urinary retention. Carbachol, induction of meiosis to relieve increased intraocular pressure of glaucoma. And both cevimeline and pilocarpine, both of them treat symptoms of dry mouth. Contraindications and cautions. We're going to assess that patient for hypersensitivity, allergy, hypotension, vasomotor instability, coronary artery disease, peptic ulcer, GI obstruction, recent GI surgery, asthma, bladder obstruction, impaired feeling of sights from a recent bladder surgery. And guys, it all makes sense if you go back and look at the therapeutic actions. Epilepsy and Parkinsonism, pregnancy and lactation. Adverse effects of the drugs. Just think about the therapeutic actions, right? What the drug's supposed to do. Then think about what if it works a little bit too well? What can happen? The adverse effects are associated with these drugs are related to the parasympathetic nervous system stimulation. What if these drugs work a little bit too well? Cardiovascular effects, bradycardia, because remember, it slows down the heart rate. Well, if it slows down the heart rate too much, it can cause bradycardia, heart block, hypotension, it brings down the blood pressure. If it does it too much, it can cause hypotension. That can even lead to cardiac arrest. GI issues, vomiting, cramps, diarrhea. Swallowing difficulties can lead to aspiration. Remember, with these drugs, the salivation increases. So they might be drooling to the point that they can aspirate on their own drool because of the increased salivation. Urinary effects include a sense of urgency. Drug-drug interactions. There's increased risk of cholinergic effects if the drugs are combined with or given with acetylcholinesterase inhibitors such as neostigmine. All right, let's talk about nursing considerations for the patient taking direct acting cholinergic agonists. We're going to assess them for contraindications such as allergies, bradycardia, vasomotor instability, peptic ulcer, COPD, GI disease, history of GI surgery, recent GI surgery, asthma, Parkinsonism, epilepsy, pregnancy, lactation. We're going to do a physical assessment of the patient. We're going to take their vital signs. We're going to assess the abdomen. We're going to also take their bowel sounds. Make sure there's no GI obstruction going on. Palpate the bladder for distension. Make sure they're not holding on to their urine. Monitor urinary intake and output. Ensure proper administration of ophthalmic preparations. Administer the oral drugs on an empty stomach. Monitor the patient closely. Look at the blood pressure, ECG, urine output, cardiac output. Maintain a cholinergic blocking drug on standby, such as atropine. Because if these cholinergic agonists work a little bit too well, we'll need an anticholinergic drug, right? So a perfect anticholinergic drug would be atropine. Make sure you have it on standby when you're giving these cholinergic agonists, just in case they work a little bit too well. Provide safety precautions. Provide safety precautions if the patient reports poor visual acuity in dim lights. We want to make sure they don't fall. Monitor urinary output. Make sure they have easy access to bathrooms. Administer oral administration of meds before meals, because remember, it has to be given on empty stomach. Before meals, without food. Now let's talk about indirect cholinergic agonist. Indirect acting cholinergic agonists do not react directly with acetylcholine receptor sites. Instead, they react chemically with acetylcholinesterase. This is the enzyme that's responsible for the breakdown of acetylcholine. There are certain indirect acting cholinergic agonists that, look at this, irreversibly bind to acetylcholinesterase. You can't reverse it. They irreversibly bind to acetylcholinesterase. These drugs are not used therapeutically. They're being developed as nerve gas to be used as weapons. Because these drugs might be encountered in a war situation, it's important to have an antidote readily available to military personnel and any civilians who might be affected. This is an antidote, guys. Paradoxical. This is an antidote developed for the irreversible indirect acting cholinergic agonist and also used to reverse poisoning that's associated with organophosphate pesticides. The reversible indirect acting cholinergic agonist falls into two main categories. One, the agents used to treat myasthenia gravis, and two, agents used to treat Alzheimer's disease. Let's talk about the agents used to treat myasthenia gravis. So myasthenia gravis, this is a chronic muscular disease that's caused by a defect in the neuromuscular transmission. It's thought to be, because we're not 100% sure of the etiology, okay? But it's thought to be an autoimmune disease in which patients make antibodies to their acetylcholine receptors. So whenever you guys see autoimmune disease, it's really the body that's attacking its own self. These antibodies cause gradual destruction of acetylcholine receptors, resulting in fewer and fewer receptor sites that are available for stimulation. Acetylcholine is a neurotransmitter that is used at the nerve muscle synapse. If acetylcholine receptors are blocked and cannot be stimulated, look what happens, guys. Muscle activity is decreased. This disease is marked by progressive weakness. As time goes on, they only get weaker and weaker because of the muscle inactivity, okay? It's marked by progressive weakness and lack of muscle control. Before I turn the page, just look at box 32.3. Do not forget paradoxical. This is the antidote for irreversible acetylcholinesterase inhibiting drugs or nerve gas. It's given IM or IV. Now back to our drugs to treat myasthenia gravis. Some patients have mild clinical presentation, such as drooping eyelids. You know you have muscles in your eyelids, right? Okay. Drooping eyelids and go into remission with no further signs and symptoms for several years. Other patients have more severe course of the disease with progressive, as time goes on, it gets worse, with progressive skeletal muscle weakness that can confine them to a wheelchair. The disease can further progress to paralysis of the diaphragm, which interferes with breathing and can prove fatal without intervention. Remember, guys, every time you take, your diaphragm sitting just like this, right under your lungs. Every time you take a deep breath, it drops down to make room for the air. And then when you breathe out, it's supposed to pop back up. Well, imagine this patient with myasthenia gravis, that muscle's not able to do that. You think that patient's lungs going to be able to expand the way it's supposed to? No. Box 32.4, safe medication administration. Let's look at myasthenia crisis versus cholinergic crisis. Take a look, guys. Couple NCLEX questions come from this. Make sure you know it. Because of the variability of the disease and the tendency to have crises and periods of remission, management of the drug dose for a patient with myasthenia gravis is a nursing challenge, because there'll be something, they'll have something acute going on with them, and they'll need more of the medication for myasthenia gravis, and they'll go into remission, and they'll need less, and then they'll need more, and then they'll need less. So it's like a balance, right? If a patient goes into remission, a smaller dosage is needed. If a patient has a crisis, and when they say crisis, we're talking about myasthenia crisis. If the patient has a crisis, an increased dose is needed. Are you guys with me so far? Okay. To further complicate the clinical picture, the presentation of a cholinergic overdose, because remember, guys, we're giving them cholinergic drugs for the myasthenia gravis, okay? To further complicate the clinical picture, a presentation of a cholinergic overdose or cholinergic crisis is similar to the presentation of myasthenia crisis. The patient with a cholinergic crisis presents with progressive muscle weakness, respiratory difficulty, as the accumulation of acetylcholine at the cholinergic receptor site leads to reduced impulse transmission and muscle weakness. This is a crisis when the respiratory muscles are involved. So it can look like myasthenia crisis, right? And if you don't understand, you'll mess around and give the patient more of the cholinergic drug. For myasthenic crisis, the correct treatment is increased cholinergic drug for myasthenia crisis. However, look at this. Treatment of a cholinergic crisis requires withdrawal of the drug. If the patient's going through a cholinergic crisis, they have too much of that cholinergic drug in them. Why would we give them more? But if the patient has myasthenia crisis, they need the cholinergic drug. The drug, and here's the drug you guys need to know, idrophonium can be used as a diagnostic agent to distinguish the two, so we can know the difference. Are they having cholinergic crisis or myasthenic crisis? That's the drug that we use, idrophonium, okay? If the patient improves immediately after idrophonium injection, the problem is myasthenia crisis, which is improved by administration of this cholinergic drug. But if the patient gets worse, the problem is a cholinergic crisis, and withdrawal of the cholinergic drug must happen. You guys see the difference? You guys see why this medication, idrophonium, is important? It's used as a diagnostic tool to tell the difference between myasthenia crisis and cholinergic crisis. Atropine, remember atropine, that's an anticholinergic. Atropine helps alleviate some of the parasympathetic reactions to the cholinergic drug. However, because atropine is not effective at the neuromuscular junction, only time can reverse that toxicity. Nurses in acute care settings, so if you're working in ICU, mostly need to be mindful of the difficulty in distinguishing drug toxicity from the need for more of the cholinergic drugs. All right, let's move on to Alzheimer's disease. Agents for Alzheimer's disease. Alzheimer's disease is a progressive disorder. As time goes on, it only gets worse. It leads to marked loss of memory or the ability to carry on activities of daily living. As time goes on, the memory, so much of the memory is lost and so much of the brain is lost, that patient may see water and they are thirsty, but they don't even recognize that water is water and it's used to drink. They can't even go to the bathroom on their own, okay? The cause of the disease is not yet known. We don't know what causes it, but it is known that there's a progressive loss of acetylcholine producing neurons and their target neurons in the cortex of the brain, specifically that part of the brain that helps with memory and functioning. There are 3 reversible indirect acting cholinergic agonists available to slow the progression of the disease. Notice it said slow the progression. Did it say cure? No, there is no cure for Alzheimer's, but there are 3 indirect acting cholinergic agonists that can slow the progression of the disease. I'm not even going to try and pronounce this medication. You see them right there. Make sure you know them. Next page, 32.2. Idrophonium, again, it's used for the diagnosis of myasthenia gravis, reversal of toxicity. Paradoxamine, management of myasthenia gravis, antidote to neuromuscular junction blockers, and increases the survival after someone's been exposed to nerve gas. Donepezil, that's known as Aricept. It's used for the treatment of Alzheimer's dementia. Exelon, I'm not going to try to pronounce the generic name of this medication. That's also for management of mild to moderate Alzheimer's disease. So these medications to treat Alzheimer's disease, therapeutic actions and indications. Remember again, guys, these are indirect. Indirect acting cholinergic agonists work to relieve the signs and symptoms of myasthenia gravis and increase muscle strength by allowing acetylcholine to accumulate in the synaptic cleft of the neuromuscular junctions. They increase acetylcholine concentration in the area of the brain where acetylcholine-producing cells are dying. They affect memory and ability to access and link different memories and use in treatment of Alzheimer's disease. Box 32.6. Namenda has been reported to slow memory loss of patients with moderate to severe dementia associated with Alzheimer's disease. Headache, dizziness, fatigue, confusion, constipation are common adverse effects of Namenda. The drug should not be taken with anything that alkalinizes the urine. Patients and family members need to understand that this drug is not a cure. It only slows the progression of the disorder. Talk about contraindications and cautions. We're going to assess the patient for allergies, bradycardia, intestinal or urinary tract obstruction, pregnancy, lactation. Caution should be used in any condition that could be exacerbated by cholinergic stimulation. This medication must be considered carefully in patients with asthma, coronary disease, peptic ulcer disease, arrhythmias, epilepsy, Parkinsonism. Drugs used to treat Alzheimer's disease are metabolized in the liver and excreted in the urine. So you better be looking at the liver function test, the BUN, creatinine, GFR. You're going to look to see how the kidney and liver is doing. Adverse effects. The adverse effects associated with agents for treating myasthenia gravis or Alzheimer's disease are related to the stimulation of the parasympathetic nervous system. So GI effects, nausea, vomiting, cramps, diarrhea, increased salivation, involuntary defecation, cardiovascular effects, bradycardia, heart block, hypotension, cardiac arrest, urinary tract effects, a sense of urgency, sphincter relaxation, meiosis. Remember, guys, that's constriction of the pupil. Meiosis and blurred vision, headaches, dizziness, drowsiness can occur. Drug-drug interactions. There may be increased risk of GI bleeding if these drugs are used with NSAIDs. The effect of anticholinesterase drugs is decreased if they're taken in combination with any cholinergic drugs because they do the opposite thing. Some reminders. Paradoxamine, remember the indications. We treat myasthenia gravis. It's an antidote for the non-depolarizing neuromuscular junction blockers, nerve gas. Make sure you know the effects: bradycardia, cardiac arrest, meiosis, salivation. The Donepezil, that's given to treat mild to moderate Alzheimer's disease. Adverse effects: insomnia, rash, muscle cramps. Nursing considerations for patients receiving indirect acting cholinergic agonists. We're going to assess them for contraindications such as allergies, arrhythmias, coronary artery disease, hypotension, urogenital or GI obstruction, peptic ulcer disease, GI or GU surgery, NSAIDs, cholinergic drugs, theophylline, that's a medication we use for asthma and other respiratory conditions, pregnancy, lactation. We're going to do a physical assessment on the patient, get a baseline. Assess their ability to carry out activities of daily living, again, baseline. We're going to take their blood pressure, pulse, ECG, check the urine output, check the renal and liver function tests. Implementation rationale. If the drug is given IV, administer it slowly to avoid severe cholinergic effects. Make sure we have atropine on standby. Remember, it's the antidote for cholinergic overdose. Discontinue the drug if excessive. That word excessive, that's another word for what? Severe, right? Excessive salivation, diarrhea, emesis occur. Frequent urination. Administer the oral drug with meals. Make sure you mark the patient's chart and notify the surgeon if the patient's to undergo surgery, that they're on these medications. Monitor the patient being treated with Alzheimer's disease for any progress, because the drug is not a cure. It only slows the progression, and you have to teach that to the family so they don't have unrealistic expectations. You're going to provide comfort measures, analgesics for headaches, safety measures, teach them small frequent meals if they have GI upset. Page 551, here's a case study. Patient's been prescribed an indirect acting cholinergic agonist. They've been given ribostagmine. You're going to teach them that this is a cholinergic agonist or a parasympathetic drug because it mimics the effects of the parasympathetic nervous system. You teach them that this drug will not reverse the memory loss. It just slows down the progress, I should say. For nausea, vomiting, diarrhea, be near bathroom facilities after taking the medication. For flushing, sweating, teach them to stay in a cool environment, wear lightweight clothing. For increased salivation, this may increase the difficulty of swallowing. For urgency to void, maintain access to bathroom. For a headache, they can take aspirin or another analgesic as ordered. Change in vision or dizziness. This might lead to falls, so we have to falls or confusion, so we have to teach them safety measures. Press the call button if you got to go to the restroom. Make sure you have the side rails up. Move slowly. Report any of these to the healthcare provider. Very slow pulse, lightheadedness, fainting, excessive salivation, abdominal cramps or pain, weakness, confusion, blurred visions, further signs of dementia. Tell any doctor, nurse, or healthcare provider involved in your care that you're taking this drug. Key points. Myasthenia gravis, remember guys, this is an autoimmune disorder. It's characterized by the patient's own antibodies. Acetylcholinesterase inhibitors, they're used to treat myasthenia gravis. Alzheimer's disease is progressive. There is no cure. And that's the end of this chapter.